So we know trigeminal when we hear, it is the only cranial nerve which has its nuclei spread along the entire brainstem. If you take a section of the midbrain, if you take a section of the pons, if you take a section of the medulla, wherever you take a section, you will get some part of this nuclei, the trigeminal nuclei. But the motor nerve part of this trigeminal nerve is very, very slender compared to the sensory part. But still, it supplies or it gives some of the motor fibers. So the question is, excuse me, can someone mute? Okay. So we know that the trigeminal nerve has got three divisions: the ophthalmic division, maxillary division, and mandibular division. Can I get the answer for this? The motor fibers pass through which division? Please type it in the chat. Very easy answer. Which division of trigeminal has the motor component? Motor component means the nerve which supplies the muscles. So I think all of you are getting settled. So we'll continue with the topic. So we have seen the mandibular nerve. The mandibular nerve means the mandibular division of the trigeminal nerve. The main part of the mandibular nerve and its branches are seen in this region, the region which you call as infratemporal fossa. So this is the sensory root of the trigeminal. This is the motor root of trigeminal, which is actually coming down to the infratemporal fossa along with the mandibular nerve. So mandibular division of the trigeminal will be having the motor fibers. The next question is, the following are the branches of the mandibular nerve except. You have the auriculotemporal nerve, you have the infraorbital nerve, you have the inferior alveolar nerve, you have the lingual nerve. So you can see that all these nerves are seen in and around face. So which of these are not the branch of the mandibular nerve? Can someone type the answer in the chat box? Anyone ready to give the answer? The following are the branches of mandibular nerve except, which is not a branch. All are almost rhyming, so you will be tempted to opt the correct answer. Yes, Joel has the answer. So let's see if he is correct. The next question is, the nerve to the mylohyoid is a branch of. Is it a branch of facial nerve, glossopharyngeal, mandibular, hypoglossal nerve? Can I get the answer for this? Nerve to mylohyoid is a branch of which nerve, which cranial nerve? Can I get the answer? Which cranial nerve has the branch to mylohyoid? Okay, so let's see who is going to answer all the questions correctly. The next question is, the following are true regarding the mandibular nerve except it leaves the cranial cavity through foramen rotundum. Buccal nerve is the only sensory nerve in the anterior division. Nerve to mylohyoid is the only motor nerve in its posterior division. It supplies all the muscles of mastication. All are true except. Can I get the answer for this? This is almost an easy question again. I have selected some of the questions which are easy so that you won't feel frustrated and you will get some of the answers also. I'm waiting for this question. The following are true except. The question is except. Joel, you are answering for this or for the previous question? Let me see the answer for this. The following are true except. Okay, so by the end of the discussion, hope you all will be able to answer this. The next question is, the mandibular nerve supplies the following non-masticatory muscles except anterobelly of digastric, mylohyoid, tensor palatini, tensor tympani, levator palatini. So the question is, which of these muscles are not supplied by the mandibular nerve? So all these are favorite questions in most of the exams. Okay, this tensor tympani, tensor palatini, mandibular nerve, all are always confusing and you will get a lot of questions from this region. That's the reason why I have added all these to today's session. So can I get the answer? I think all of you are getting settled. So we will have the explanation and we will see the answer. Now, just match the following. So for this, you need to know how the mandibular nerve is dividing and how are you getting the branches from each division. So there is a trunk for the mandibular nerve which enters into the infratemporal fossa through foramen ovale. Then it divides into anterior and posterior division. So you need to know which are the branches coming from the trunk, which are the branches coming from the anterior division, and which are the branches from the posterior division. So for this, you need to know what are the divisions and branches of the mandibular nerve. So with this, we are going to the discussion about the mandibular nerve. So this is the cranial fossa, and you can see the stout one, that is the trigeminal nerve. And you can see that it is dividing into three divisions. You have the ophthalmic division, you have the maxillary and mandibular. And this mandibular nerve is making its exit from the cranial cavity through foramen ovale. And through the foramen ovale, it is having a communication with the infratemporal fossa. So this is the infratemporal fossa region. And there you have the trunk of the mandibular nerve. And after that, you can see that it is dividing into anterior and posterior division. From the anterior division, you can see there is one nerve marked as buccal nerve. And from the posterior division, you can see there are branches marked as auriculotemporal, then you have the inferior alveolar, then you have the lingual nerve, and then you have the nerve to mylohyoid. Then you can also see a nerve which is joining the lingual nerve from its posterior aspect. And that you can see a cut end of the nerve here also. So this is the cut end of the facial nerve which is entering into the parotid gland, and this is the chordae tympani branch of the facial nerve which is emerging through the petrotympanic fissure from the middle ear. Okay, so you have the chordae tympani joining the lingual nerve. So all these are important concepts which you need to know. So I have shown the trunk of the mandibular nerve. So all these events are happening in the infratemporal fossa. So you can see that this is a trunk of the mandibular nerve which is dividing into the anterior division and posterior division. Anterior division, I have only marked one nerve, that is the buccal nerve. That doesn't mean that they are not having any sensory branches, any other branches. It means the anterior division is mainly motor. That is, it is supplying the muscles of mastication. You have the temporalis, you have the lateral pterygoid, you have the masseter. So all these are supplied by the anterior division, and it has got only one sensory nerve, that is the buccal nerve. But when you look at the posterior division, you can see that the auriculotemporal nerve, the inferior alveolar, the lingual nerve, all these are mainly sensory. And you can see a branch coming from the inferior alveolar before it enters into the mandibular foramen. So that is the nerve to mylohyoid, which travels anteriorly and supplies the mylohyoid muscle and also the anterior belly of digastric. So this is the motor component of the mandibular nerve from the posterior division. So posterior division is mainly sensory and anterior division is mainly motor. Now this buccal nerve. So you might have studied about the buccal branch of facial nerve. But here it is just the buccal nerve. So buccal branch of facial nerve is a motor branch to the buccinator, whereas this buccal nerve is the sensory branch which supplies the mucosa and the outer aspect of the cheek. Okay, so you don't confuse between these two nerves. Buccal nerve and buccal branch of facial nerve, both are different. Buccal nerve is the sensory branch of the anterior division of mandibular nerve, whereas buccal branch of facial nerve is the motor branch which supplies the muscle. So this is very, very important, the mandibular nerve and its subdivisions. Now, this is the inner aspect of the mandible. You can see the inferior alveolar nerve entering through the mandibular foramen. So before it enters into the mandibular foramen, it is giving off a branch. That is the nerve to mylohyoid. So this nerve to mylohyoid, it won't enter through the mandibular foramen along with the inferior alveolar nerve. And the nerve to mylohyoid will travel anteriorly and it will supply two muscles. It is mylohyoid and anterior belly of digastric. So digastric muscle again is a very favorite question. Digastric muscle has got two bellies, anterior belly and posterior belly. Anterior belly get its nerve supply from this nerve to mylohyoid, whereas the posterior belly of digastric is getting its nerve supply from the facial nerve. So you please remember this as well. So now can you answer the question for this question? The following are the branches of the mandibular nerve except. So I have mentioned the branches, the main branches. Now can I get the answer for this? Yes, Lebin, very good. It is infraorbital. So infraorbital is not a branch of the mandibular nerve. Now the nerve to mylohyoid is a branch of nerve to mylohyoid. Very easy again. We are discussing about which nerve. So that is the nerve which is giving the branch, the nerve to mylohyoid. Yes, very good, Lebin. It is mandibular nerve. There is no confusion about this. Now coming to the next, they are true except. Which is the answer for this? Again, very easy. Yes, Lal has the correct answer for this. It leaves the cranial cavity. It's not through foramen rotundum. Foramen rotundum is for the maxillary division of the trigeminal nerve. The mandibular nerve leaves the cranial cavity through foramen ovale, which is having a communication with the infratemporal fossa. So I would like to add some points here. In the cranial fossa, you have the anterior, middle, and posterior cranial fossa. And in the middle cranial fossa, you have major foramina like you have the foramen rotundum, you have the foramen ovale, you have the foramen spinosum. So these are the three important foramina which you get in order. I prefer to give the code ROS. So R for rotundum, O for ovale, and S for foramen spinosum. Out of these three, only ovale and spinosum, they are the ones which are opening into the infratemporal fossa. But what happens to the foramen rotundum? It is opening to some other region. Can someone say the opening of foramen rotundum? To which part the foramen rotundum opens into? Foramen rotundum opens into which region? And because of its opening to that region, you have an important structure passing through foramen rotundum. I have already mentioned that the structure is maxillary nerve, maxillary division of the trigeminal, which we call it as maxillary nerve. So can someone say where the foramen rotundum is opening into? It's a fossa starting with P, where P is silent. Can someone type the name of the fossa into which foramen rotundum is opening? Yes, it is. Yes, Varunka, it is pterygopalatine fossa. Very good. So that's about the foramen rotundum. So it's not the mandibular nerve which is passing through foramen rotundum. The mandibular nerve supplies the following non-masticatory muscles. So it is specifically mentioned as non-masticatory because muscles of mastication are supplied by the mandibular nerve. We all know it. So there are some other muscles which are also supplied, which are non-masticatory in function, which are supplied by the mandibular nerve. So I have already mentioned all the branches. So two branches I haven't mentioned. I will mention it after this. So can I get the answer for this? Can I get the answer? Except is the question. Can I get the answer for this? Two I have already mentioned, but the other three options I will explain once I get the answer for this. So which is the exception? Can someone say the mandibular nerve supplies all except? Just type. Let's see how many of you are going correct. Yes, Varunka, query, you have at least a doubt. So the answer is yes, you're right. So the thing is, this tensor veli palatini and tensor tympani, they are actually supplied by, we didn't mention these muscles when we discussed about the anterior and posterior division of the mandibular nerve. So where are these branches coming from? I mentioned that there is a trunk for the mandibular nerve. So from the trunk of the mandibular nerve, there is a nerve arising that is called nerve to medial pterygoid. So out of the four major muscles of mastication, which we call as medial pterygoid, lateral pterygoid, temporalis, and masseter, out of these four major muscles of mastication, medial pterygoid is getting its nerve supply from the trunk of the mandibular nerve. So that is called the nerve to medial pterygoid. So this nerve to medial pterygoid, apart from supplying the medial pterygoid muscle, it's actually proceeding forward after supplying it to supply two more muscles. They are the tensor veli palatini and tensor tympani. Okay, this is very, very important. So it's not the levator palatini muscle which is supplied by the mandibular nerve. Hope that's clear for you now. Now, can someone try to match it? From the trunk, I have already mentioned it, which the muscle which is supplied by the mandibular nerve from its trunk. Which all option? One matches with what? Two, posterior division matches with what? Let me see who is going to do it correctly. So if you answer this question correctly, that means you know everything about the mandibular nerve, the branches, how are they dividing? So can I get the answer for this? It's actually a very easy answer after the discussion. All these are high yield areas. You will get at least one or two questions, I'm damn sure. Sometimes it will come under anatomy, or these questions are favorite topics for ENT as well, the head and neck region. So can I get the answer for this? Okay, so let me answer for you. So the trunk, you have the nerve to medial pterygoid, which also supplies tensor veli palatini and tensor tympani. From the posterior division, you have all the sensory branches. Apart from that, you have the nerve to mylohyoid, which supplies mylohyoid as well as the anterior belly of digastric. And the last, from the anterior division, you have the muscles of mastication except the medial pterygoid, because medial pterygoid is getting its nerve supply from the trunk of the mandibular nerve. Okay, so hope this is clear for you. Now the next question is, local anesthetic agent injected around the mandibular canal blocks the transmission of the impulses through which nerve? So mandibular canal, I have mentioned the nerve which is passing through the mandibular canal. Now can you answer whether it is mental, lingual, inferior, alveolar, or mandibular nerve? Can I get the answer? Yes, I think Varun Kalibin. This is an easy question, I guess. So let's see how this is related. So you can see the mandibular canal. You have the mandibular foramen, and through which you have the mandibular canal, which is running through the body of the mandible. So if you inject something here, which is the nerve related, you have the inferior alveolar nerve. So this nerve is usually the nerve which is used by the dentist to anesthetize the lower part of the mandible. If they do some extraction of the tooth here, they will be anesthetizing this nerve, and which ligament will help them to locate this point. There is a projection here called lingula, and there is an attachment for a ligament here, and they will, with the help of their fingers, try to identify this ligament so that they can reach this foramen. So can someone say which is the ligament which is related to the projection here, which you call as lingula? Which ligament will the dentist palpate to locate this point in order to give a block to the inferior alveolar nerve before any tooth extraction? Can someone mention the ligament? It starts with S. Can someone say? Let me see. It's again a very easy, because we always discuss this lingula and the attachment. That is the sphenomandibular ligament. Okay, so please keep that also in your mind. Now, If you have to give a block to the mandibular nerve as such, if you have to give the entire the block to the entire mandibular nerve and its divisions, where will you give the block? So it is at this region that is called the mandibular notch. Okay, so through the mandibular notch, you can reach the infratemporal fossa, where you have the mandibular trunk and you have the division. So all these nerves, auriculotemporal nerve, inferior alveolar, lingual, the buccal, all these can be anesthetized. Okay, so local anesthetic agent injected around the mandibular canal, it is focusing on, now can you answer which nerve they are focusing? If they inject at the mandibular canal, which is the option? Can I get the option here? Yes, lal. So lal libin. Okay. So it is the inferior alveolar. Which of the following nerves carries the risk of being damaged while extracting the lower third molar tooth? So suppose if the dentist is removing that nerve, sorry, that tooth, accidentally, they can injure the nerve which is lying very close to that tooth, the third molar. So which nerve are you afraid of injuring? Can someone say? The third molar tooth. So you might get a question as a clinical scenario. Sorry, it's not. Okay, someone lal. Yes. So let's see what is the answer for this. So I have shown the mandibular foramen and the canal and all. I have shown the inferior alveolar, but there is one more nerve which is lying anteriorly, and that is the nerve which is lying closer to the third molar tooth. Okay, so and that nerve is lingual nerve. So it's not the inferior alveolar, okay, which has got a higher chance because it is actually safe inside the canal. But this lingual nerve is more closer to the third molar. So any tooth extraction in this region can injure the lingual nerve. And lingual nerve, apart from that nerve alone, you have a branch of the facial nerve which you call as chordae tympani, which is joining the lingual nerve. And can someone say the function of chordae tympani? Why this chordae tympani is joining with the lingual nerve? Why this chordae tympani of the facial nerve is joining the lingual nerve? Can someone say the answer for this? Why you have the chordae tympani? Yes, anterior two-third, what? Anterior two-third, yes, Libin, you are right. But anterior two-third, what? Chordae tympani, what sensation? You are right again. But what sensation? I need to know the sensation, type of sensation. Very good. So it is the taste sensation which you get. Yes, Vaishak. Uh, so this is how you view it from the posterior aspect. You have the third molar, you have the lingual nerve, which is more in contact with the third molar tooth. Okay. Now, which of the following nerves carries the risk of being damaged? So this is the lingual nerve. Select the incorrect statement about the lingual nerve. It's a branch of the anterior division of the mandibular nerve. It is purely a sensory nerve. It is joined by the chordae tympani of the facial nerve. It innervates the anterior two-third of the tongue. So this again is a very easy answer now since we have discussed about it. What's it? Yes, Libin. So what is it? We have already discussed the anterior division and posterior division. So you have the lingual nerve, chordae tympani joining the lingual nerve. So your lingual nerve is from the posterior division. Okay. So this is the mandibular nerve coming through the foramen ovale. So you have the lingual nerve and you have the facial nerve, which is giving off the chordae tympani, which is joining the lingual nerve. So here the answer is, the incorrect statement is the anterior division. It is not the anterior division of mandibular nerve giving rise to the lingual nerve. It is the posterior division. So posterior division is mainly sensory and anterior division is mainly motor. The only sensory branch from the anterior division is buccal nerve. The motor branch from the posterior division is nerve to mylohyoid, which also supplies anterior belly of digastric. So that's about the mandibular nerve in a nutshell. Now, injury to the lingual nerve close to the lower third molar tooth can affect on the side of involvement. General sensation from the anterior two-third of the tongue, sensation of taste from the anterior two-third of the tongue, salivation from the submandibular and sublingual salivary glands, all of the above. Can someone say the answer for this? Can I get the answer? Libin, you have answered for this or? So this is a bit tricky. So whenever you have this all of the above, none of the above, some of the options clubbed together, sometimes it can be a distractor, but sometimes they can be the answers as well. So if the lingual nerve as such is tempered, what will happen? That is the question. So lingual nerve is not just lingual nerve alone. You have the chordae tympani also running with the lingual nerve. You have to remember that point. And you also need to know which is the ganglion related to the lingual nerve. So in the previous session, I've already mentioned that this head and neck region has got 4 parasympathetic ganglia. We'll come to it. The otic ganglion, the ciliary ganglion, then the pterygopalatine ganglion, the submandibular ganglion. So one ganglia is also related to the lingual nerve out of these 4. And through that, you have the glands supplied. Now, can you answer? I'm waiting for the answer. At least one of you might get it correct from the explanation which I have already given. Can I get the answer? Yes, Varunka, since yes, Libin, I have mentioned that sometimes it can be a distractor, right? Yes, so it is the all these statements are correct because you will have the general sensations gone because the lingual nerve is supplying the anterior two-third. Then the taste sensation also will be gone from the anterior two-third because the chordae tympani is joining the lingual nerve. Excuse me. Now, the lingual nerve is giving the branches to the ganglion through which the presynaptic and postsynaptic fibers, which will actually provide the secretomotor innervation to the submandibular and sublingual salivary glands. So, salivation also will be affected. Okay. Now, the following statements are true about the maxillary artery, except it's a branch of the internal carotid artery. It arises behind the neck of the mandible. It gives off the accessory meningeal artery. It ends in the pterygopalatine fossa. It's very easy thing, isn't it? Can I get the answer? I'm not seeing the name of the person, but I'm seeing some mobile name, so I can't call the person. Okay. So anyway, I got the answer correctly. So let's see how it is. Which part of the lateral pterygoid muscle is related to the first part of the maxillary artery? So I would like to add a point at this juncture, that is, if we take the infratemporal fossa, there is a key muscle there in the infratemporal fossa. So most of the regions in the body, if you call a muscle as a key muscle, that means you can explain the structures in that region with respect to that muscle. Okay. So in the infratemporal fossa, the muscle which you get is the lateral pterygoid. And you have the maxillary artery. Excuse me. Sorry, I have a irritant throat. Now the question is, you have the lateral pterygoid in the infratemporal fossa, and you have the maxillary artery, which is divided into 3 segments based on this lateral pterygoid. So which part of the lateral pterygoid is actually dividing. So whether it is lower border, whether it's superficial surface of the lower border, deep surface, gap between the upper and lower heads. So can I get the answer for this? We'll be discussing all these things. After that, it will be easy for you. Can I get the answer? Okay, so we'll see it. So here you have the external carotid artery. And first and foremost thing is, the internal carotid artery is actually going into the cranial cavity to supply the brain. And the major portion of the head and neck get its branches from the external carotid artery, which is lying outside. Of course, at the angle of the eye, you have an anastomosis happening between the external and internal carotid. I think I discussed it during the last session. So, but when we discuss about the major arterial supply of the head and neck, it comes from the external carotid artery. And we know the external carotid artery is dividing into the two terminal branches, the maxillary artery and the superficial temporal artery. And the maxillary artery is related to the neck of the mandible. Okay. Now, you have the maxillary artery, you have the middle meningeal artery here. And let's see how this is divided into three parts. So the first part is from its point of origin. And this is, so before that, you need to know that the lateral pterygoid has got two heads, the upper head and the lower head. Okay, so the lower head, the lowermost point. So from the point of origin to the lower part of the lower head, you have the first part. And the second part is from this point up to the entry into the pterygopalatine fossa. Okay, so this portion is called the pterygomaxillary fissure. So the second part can be either above or below the lower head of the lateral pterygoid, and the third part will be entering into the pterygopalatine fossa. So these two parts, the first part and the second part, are the two parts which you will be visualizing in the infratemporal fossa. Okay, so you have the middle meningeal artery, one of the important branches coming from the first part. So the following are true, except now it's very easy. I've already mentioned one of the important concepts of the arterial supply of the head and neck. So which is the exception? Can I get the answer for this? It's a branch of. Yes, very good. It's not internal carotid artery, isn't it? So it is the external carotid artery. Okay. Now, what is this? Which part of the lateral pterygoid muscle related to the first part of the maxillary artery? Which part? Yes, Hindu Krishna, yes. So it is the lower border of the lower head of the lateral pterygoid. A true statement about the middle meningeal artery is, middle meningeal artery, you know, it's a very important branch which is closely related to the pterion, the weakest point of the skull where you will get it injured. So, which is a true statement. Is a branch of the second part of the maxillary artery. It enters the skull through the foramen spinosum. Its posterior division is related to pterion. It is involved in subdural hematoma. So, can I get the answer for this? Which is the true statement? Yes, of course, I mentioned the middle meningeal artery related to pterion, but I didn't mention which division. You get hematoma, but it's not subdural. So let's clear some of the concepts like this. So you have the middle meningeal artery, which is actually arising from the first part of the maxillary artery. And you will be seeing the middle meningeal artery in the infratemporal fossa. From the infratemporal fossa, it is entering into the cranial cavity. So, through which part of the cranial cavity it will enter? It is entering through the foramen spinosum. And there it divides into the anterior or frontal division or frontal branch or parietal. Someone please. Sorry, my network was having some issue. Okay, so pterion, we were discussing about the branches of the pterion. At the pterion, the middle meningeal artery. Okay, so middle meningeal artery, it divides into two branches, the anterior or frontal branch and the posterior or parietal branch. So it is the frontal branch which is in close vicinity of pterion. Okay. So you can see the maxillary artery, you can see the middle meningeal artery entering into the cranial cavity through foramen spinosum, and it is the anterior division. Now coming to the hematoma. So where is this artery lying? It is lying between the skull and the dura mater. Okay, so this is lying between the skull and the dura mater. So if there is any bleed, suppose if you get a fracture at the pterion and if you get this middle meningeal artery injured, you will get bleeding from the middle meningeal artery, and this blood will be collected between the dura and the skull. So this is actually a case of extradural hematoma. So when we discuss about the meninges of the cranial cavity, and the meninges of the spine, covering the spinal cord, there is one major difference. When we discuss about the dura mater of the cranial cavity, there are two layers for the dura. You have an endosteal layer and meningeal layer. Endosteal layer will be actually closely plastered to the interior of the cranial cavity, and the meningeal layer will be in contact with the brain as such. So there is no space between the dura and the bone. But if you get any blood collected, that will create a space. So there is no dead space actually, but if there is any bleeding outside the dura, the endosteal layer, a space will be created, and that will result in extradural hematoma. But when you consider the meninges covering the spinal cord, this endosteal layer is not actually going through the foramen magnum to cover the spinal cord. It will end at the borders of the foramen magnum, and only the meningeal layer is getting carried along the spinal cord. So, what will happen if you consider the vertebral canal? There will be a space between the dura mater and the bone, and that is called as the epidural space. So, there is a space in the spinal cord, whereas in the cranial cavity, there is no such space, but a space is created if there is a bleeding coming from the artery in this region. And the artery in this region, which is lying between the dura and the bone, is the middle meningeal artery. So, it's not the subdural, it is the extradural hematoma. Hope this idea is clear. This is again very common question which is asked. So what is the true statement about the meningeal artery here? Can I get the answer now? Can I get the answer? It's very easy now. I have explained the concept behind the middle meningeal artery. Can I get the answer for this? So I think I will have to answer. The true statement is it is entering into the skull through the foramen spinosum. Okay. Yes. Now the following are the branches of the third part of maxillary artery except. So third part of maxillary artery is the part which is entering into the pterygopalatine fossa. So which is not a branch from the third part. So if you know the other branches, you can easily answer this. Can I get the answer for this? So you can see the infraorbital artery of pterygoid canal, superior alveolar. Okay, so all these are from the third part, whereas the inferior alveolar is actually from the other region. Okay, so mental artery, which is a continuation of the inferior alveolar. The sphenopalatine. So That's that's again not commonly asked, but from the first part, you have the middle meningeal artery. That you have to always remember. Okay, and the second part, it is mainly muscular branches. Muscular branches means the muscles of mastication. You have the branches of the muscles of mastication coming from the second part. So that also you have to remember. Now, the largest of the parasympathetic ganglia, I have discussed there are about the parasympathetic ganglia which you get in the head and neck region. The four main ganglia being the otic ganglia, ciliary ganglia, submandibular, and sphenopalatine. And the next question is, which is the largest of the parasympathetic ganglia? Can I get the answer for this? Which one is the largest? Can someone type the answer for the same? Which of these ganglia? Why don't I think you need to have a look again, which is the largest. Yes, Arya. So let's see the ganglia. So you have the pterygopalatine fossa here, where you have the pterygopalatine, otherwise known as sphenopalatine ganglia. Okay, so the largest of the parasympathetic ganglia is sphenopalatine or pterygopalatine. Now, match the following parasympathetic ganglia with the appropriate nerve topographically connected to them. So, whenever you discuss about a parasympathetic ganglia in the head and neck region, there are some nerves which are actually suspending the ganglia, but they are not having any connections with the ganglia. That means the functional component is not coming from that nerve. It is just helpful for suspending the ganglia. That is what is meant by topographical. Okay, but functional component will be coming from some other nerve. So that means in some regions, when you have the ganglia, the nerve in that region will be helping to suspend that ganglia. That is known as topographically related. Okay, so we have the ganglia here, the ciliary ganglia, submandibular, otic, and pterygopalatine. And you need to know which are the nerves suspending these ganglia, whether it is maxillary nerve, mandibular, nasociliary, and lingual. Can someone try to get it correctly? One goes with what? So I will just quickly discuss about the same. You have the pterygopalatine ganglion in the pterygopalatine fossa, and there is a nerve related to the pterygopalatine fossa. So that is the maxillary nerve. So maxillary nerve actually suspends the pterygopalatine ganglion. Then this is the submandibular ganglion, and that is actually suspended by the lingual nerve. Okay, so the nerve which is suspending these ganglia are known as topographically related nerves. Now, the next one is in the orbit, that is the ciliary ganglion. So this is suspended by the branch coming from the ophthalmic division of the trigeminal nerve, that is the nasociliary nerve. And the fourth one is the otic ganglion, which is seen in the infratemporal fossa, and that is related, topographically related or suspended from the mandibular nerve. Okay, so you have to think about the nerves in each region. You have the pterygopalatine fossa, you have the submandibular region where you have the submandibular ganglion, then you have the orbit with the ciliary ganglion, and you have the infratemporal fossa with the otic ganglion. So these are the nerves. So you have the ophthalmic, maxillary, mandibular, and the branch of the mandibular. You just think about these nerves which are suspending it. So from the ophthalmic, you have the nasociliary suspending the ciliary ganglion, the maxillary suspending the pterygopalatine ganglion, mandibular mainly suspending the otic ganglion, and the branch of the mandibular lingual nerve suspending the submandibular ganglion. Okay, so this is a very, very important concept. You have to know it because many questions are asked from these parasympathetic innervation. Okay, so now it's easy for you. Ciliary, nasociliary nerve, the submandibular related to lingual nerve, otic related to mandibular nerve, and the pterygopalatine related to maxillary nerve. Okay, now the next. Select the incorrect statement about the otic ganglion. It lies close to the foramen ovale. It sends postganglionic fibers through the auricular temporal nerve. It communicates with the nerve of the pterygoid canal and chordae tympani. It is concerned with the secretomotor innervation of the lacrimal gland. This is very easy, right? Can I get the answer for the same? Incorrect statement about the otic ganglion, which is incorrect. I have mentioned which are the glands related to the ganglia. So what can be the answer? Yes, Levin. Let's see the answer. So you have the otic ganglion, you have the mandibular nerve suspending the ganglion through the foramen ovale. Then you have the auricular temporal nerve, which are carrying the fibers. Okay. Then this is chordae tympani joining the lingual nerve. Now, I mentioned about the tensor tympani and tensor veli palatini. They are actually getting the branches through the nerve to medial pterygoid. So here the answer is, it is not concerned with the secretomotor innervation of the lacrimal gland. It is concerned with the secretomotor innervation of the parotid gland. Which of the following synapses with the cells in the otic ganglion? Lesser petrocell, fibers from the middle meningeal plexus, nerve to mylohyoid, sensory roots from the auricular temporal nerve. Which of the following synapses with the cells in the otic ganglion? Can I get the answer? So you can actually remember it as ITT lower. The otic ganglion, the secretomotor innervation to the parotid gland, is actually considered as ITT lower. Easily remembered as ITT lower. I stands for inferior salivatory nucleus. T for tympanic branch of glossopharyngeal. The next T for tympanic plexus. Then L for lesser petrocell. O for otic ganglia. And A for auricular temporal. Now can we answer this? So you have the otic ganglion, you have the lesser petrocell nerve carrying the preganglionic fibers, which are reaching the ganglion to make the synapse. And the postganglionic fibers are carried by the auriculotemporal nerve. So they are the parasympathetic secretomotor fibers. Okay, so it is the lesser petrosal nerve. It is not the sensory root of the auriculotemporal. What type of joint is the temporomandibular joint? Again, very easy. What type of joint is the temporomandibular joint? Ball and socket, condyloid, hinge, saddle. Which part of the mandible is articulating with the temporal bone to form the TMJ? That will give the answer for this. Can I get the answer? Temporomandibular joint is what type of joint? Yes, Levin, very good. So it's a condyloid type of joint. In dislocation of the temporomandibular joint, the position of the head of the mandible to the articular tubercle. When you get an anterior dislocation, usually the temporomandibular joint dislocates anteriorly. So where is the position of the head of the mandible with respect to the articular tubercle? It's there in the sentence which I have made. So let's see, many of you are going wrong with that. So this is the normal, and you have the articular tubercle already anterior to the joint. But when there is any dislocation, this will actually gets dislocated from the socket and it will lie anterior to the articular tubercle. Okay. It's a very easy thing. All these things can be asked as a part of the radiological assessment as well. Sometimes an X-ray will be shown with the TMJ dislocated, and this will be pointed and will be asked what is the structure. Okay, so articular tubercle is very, very important. You have to know this is the identifying feature of the TMJ joint dislocation. Which of the following nerve lies in close proximity with the TM joint? Greater auricular, posterior auricular, auriculotemporal, zygomaticotemporal. Can I get the answer? Which nerve? Because whenever there is a dislocation of TM joint, we have to think about this nerve injury as well. TM joint dislocation is a very common thing, and in casualty, we can reduce the dislocation very easily. It's not a major procedure. But if it is not identified correctly and not reduced, then the nerves which are lying closer can be injured. So you need to know which is the nerve. Can I get the answer for this? So it is the auriculotemporal nerve. Okay, so auriculotemporal nerve is the nerve which is lying very close to the TM joint. So you know how serious it is if it is not attended properly. The following are the contents of the pterygopalatine fossa, except chordae tympani, maxillary artery, maxillary nerve, sphenopalatine ganglion. Again, a very easy question, which is not the content in the pterygopalatine fossa. Pterygopalatine fossa is exclusively related to which ganglia and vessel? That will give you an answer. Libin, I think the question is except pterygopalatine fossa. So let's see the pterygopalatine fossa. It is here. You can see the pterygopalatine ganglion. You can see the maxillary nerve, which is suspending the ganglion. You can see the artery, maxillary artery, the third part of the maxillary artery, which you get in the pterygopalatine fossa. Okay, so it's not chordae tympani. Chordae tympani is seen in the infratemporal fossa, right? So it's not the chordae tympani which you get in the pterygopalatine fossa. Now, the preganglionic parasympathetic fibers to the sphenopalatine ganglion pass through. So, how the functional component of the sphenopalatine ganglion reaches the ganglion? That is the question. Through which nerve? Greater palatine, lesser palatine, nasopalatine, nerve of pterygoid canal. So, the four options, all these are rhyming with palate. So, they are again distractors. But one is entirely different, so that can also be considered as a distractor. So think about it, we'll see it. The following statements are true about the nerve of the pterygoid canal, except it is formed by the union of the greater and lesser petrosal nerve. It carries both sympathetic and parasympathetic fibers. It is accompanied by the artery of the same name. It sends secretomotor fibers to the lacrimal gland. So can I get the answer? Let me see who is going to answer it correctly. It's a very interesting question. You need to know the concept behind it. So let me see who is actually going to make it correct. Can I get the answer? Nerve of pterygoid canal. I'm waiting. I think many of you are reluctant to answer it. So let's see. So you have the greater petrosal and it is not lesser petrosal. It is deep petrosal nerve. You have greater petrosal nerve, lesser petrosal nerve, deep petrosal nerve and external petrosal nerve. Okay. So here we are talking about the nerve of the pterygoid canal that is formed by the combination of greater petrosal nerve and deep petrosal nerve. Okay, you have to remember this. Now it is entering into the pterygoid canal, hence called the nerve of pterygoid canal or median nerve. So this is actually opening into the foramen lacerum. This opening of the canal is into the foramen lacerum posteriorly. And anteriorly, the pterygoid canal is opening into the pterygopalatine fossa, where it is entering to the pterygopalatine ganglion. Okay, so the deep petrosal nerve is actually the sympathetics winding around the internal carotid artery. So they are the sympathetics. And it is the greater petrosal nerve which is parasympathetic. So sympathetic and parasympathetic combination. Okay, entering through the pterygoid canal. And we know the pterygopalatine ganglion is concerned with what? The pterygopalatine ganglion, its main function is to go and stimulate the lacrimal gland through the zygomatic nerve and the lacrimal nerve. Okay, so though it is lying here, it is controlling many glands in the palate, in the nasal cavity, and also the lacrimal gland. Okay, so the preganglionic fibers pass through the nerve of the pterygoid canal. The following statements are true except it is not greater and lesser petrosal nerve. It is greater and deep petrosal nerve. The key muscle of the submandibular region is. Can I get the answer for this? The key muscle of the submandibular region. So I have already mentioned that there are some muscles in each region. In the infratemporal fossa, we just discussed about the upper and lower head of the lateral pterygoid. The question here is, which is the key muscle in the submandibular region? Very easy. Because with respect to that muscle, we mention it as the structures lying above it, below it, superficially related, deeply related. It's again a very favorite question. Varun, I think we need to think about it again. Govind, I think you might have got it confused, or let's see. So, in the submandibular region, you have a very important muscle called hyoglossus. Okay, so it is the hyoglossus with respect to which we discuss about the structures in this region. Okay, so hyoglossus is the key muscle of this region. The following structures lie on the superficial surface of the hyoglossus muscle, except. So that's again a very important aspect. Hyoglossus muscle has got many structures lying over it and some structures which are lying under it or deep to it. So you have the lingual artery, you have the hypoglossal nerve, you have the submandibular ganglion, you have the deep part of the submandibular salivary gland. So which is not lying over the hyoglossus? That is a question. Can I get the answer for this? Please type the answer which is not lying over it. Can I get the answer? It's a bit tough, I guess. So let's see. This is the hyoglossus muscle, the chief muscle of the or the key muscle of the submandibular region. You can see many structures lying over it, isn't it? You can see the lingual nerve suspending the ganglion, that is the submandibular ganglion. Then you have the submandibular gland, the deep part. Then you have the hypoglossal nerve. So all these are structures which are lying over the hyoglossus muscle. But there is one structure which is going deeper to the hyoglossus. That is the lingual artery. So that is the exception here. Okay. Now the submandibular ganglion is suspended from which nerve? Topographically related, we discussed it in a different context. So which is the nerve which is suspending the ganglion? It's very, very easy. Yes, Indu. Okay. So the answer is lingual nerve. Very easy question, isn't it? Now incisions through the mucous membrane of the floor of mouth give access to the following except. That is, if you want to approach some of these structures, you can do it just by putting an incision in the mucous membrane. So all except sublingual salivary gland, anterior superior alveolar nerve, submandibular salivary duct, lingual nerve. What can be the answer? Which is not accessible. So you can see this is when you put an incision, you can approach the sublingual salivary gland, you have the submandibular duct, you have the lingual nerve. Okay. So these are some of the views which you can make out: the submandibular duct, the sublingual gland, the deep part of the submandibular gland, but not the anterior superior alveolar nerve. Okay, so that is not easy when you put an incision on the floor of the mouth. From the term itself, you know that it is superiorly located. It's not inferiorly located. So all the other structures, sublingual salivary gland, submandibular, lingual nerve, even if you don't know the exact location of all these structures, you can just identify the odd one out, isn't it? So it is the superior, anterior superior alveolar nerve. So that is in the upper part, it's not on the floor. Okay. The tongue is attached to the following except. You have the mandible, you have the hyoid, you have the epiglottis, you have the thyroid cartilage. What is the exception? Let me see. It is again a very easy thing. Can you get the correct answer for this? Tongue is not attached to which bone? Can I get the answer? Many of you are going together with your answer, but I need to know whether it's correct or not, right? So let's see. So you have the tongue, you have the epiglottis. It's just asked whether it is attached. Yes, there is a connection between the epiglottis and the tongue. You call it as glossoepiglottic folds. Okay. Then with the mandible, yes, of course, you have the genial tubercles, the genioglossus. Then hyoid, you have the hyoglossus. So the one which is not having any connection is the thyroid cartilage. Now the next question, which of the following nerves supply the most of the tongue muscles? Glossopharyngeal, vagus, accessory, hypoglossal. This is a very easy question, right? The chief nerve of the tongue, the motor supply to the tongue. Which is the answer? Can I get the answer for this? The main nerve supply, the motor nerve supply. It's not sensory, most of the tongue. Motor nerve, it's not sensory which is asked, it is motor. Can I get the answer? So let's see the hypoglossal nerve. Okay, so whenever you think about the tongue, the motor supply, the major nerve supplying all the muscles of the tongue, it is the hypoglossal nerve. Okay, so hypoglossal nerve is the main nerve which is supplying the tongue. except the palatoglossus. Okay, so the only muscle of the tongue not supplied by the hypoglossal nerve is, I have just mentioned it. Let me see who is listening. Which is the answer here? Except, yes, Vaishak, Indu. So it is the palatoglossus which is not supplied by the hypoglossal. The palatoglossus here is supplied by the pharyngeal plexus through a complex formed by the vagus nerve. Okay, so vago-accessory complex. So that is supplying the palatoglossus. So all the rest of the muscles of the tongue, whether it is intrinsic or extrinsic muscles, they are supplied by the hypoglossal nerve. So the hypoglossal nerve is very, very important. That is the chief nerve of the tongue. Which of the following papillae is abundant on the dorsum of the tongue? Which is the most commonly seen papillae? Fungiform, filiform, circumvallate, foliate. Most common papillae. No. Many of you are going with circumvallate. It's not the answer. Which is, yes, Vaishak. So, which is the answer? It is the filiform papillae. Okay, or filiform papillae. But though you get this numerous, what is the peculiarity of filiform papillae? Can someone answer? Yes, Vaishak, you know the answer? Though we say that filiform papillae is seen more compared to all the rest of the papillae, what is the peculiarity of the filiform papillae, or what is the function of this filiform papillae? The interesting part here is the filiform papillae doesn't have any taste bud. Okay, so when you think about the function, it helps to hold the food in position. That is the only thing. Whereas the fungiform, circumvallate, and foliate and all, they have the taste buds. Okay, but the most numerous among the various papillae, the answer is the filiform papillae. Okay, so that's again very, very important. The sulcus terminalis, the V-shaped sulcus, which you get on the dorsum of the tongue, marks a change of the following except. Is it a demarcation between the general sensory innervation or the embryological origin or the lymphatic drainage or the nature of epithelium? Whether all are right or is there anything wrong? Is it marking any demarcation? That is the question. Sulcus terminalis. This is again a very, very important concept. Yes. So except the epithelial lining. Epithelium is not changing at the level of the sulcus terminalis, right? Which of the following tongue muscles can produce airway obstruction on total relaxation during general anesthesia? Normally, when we see people falling unconscious, we always try to keep them on the lateral position, isn't it? So that we can prevent the trunk from falling backwards. So this is actually asked in a different way. You have to correlate all these things. Okay. Or which is the safety muscle of the tongue? All these are questions. So can I get the answer for this? Yes. Arya, Varunka. Yes. What is the answer? It is the genioglossus. You can see the genioglossus here. That is the one which prevents the tongue from falling backward. So if the tongue falls backward, it can obstruct the airway and hence it is called the safety muscle. So if during anesthesia as well as when someone fell unconscious, what you do is we make them lie on the lateral aspect so that you can prevent the tongue from falling backwards and obstructing the airway. Okay. Now the next one, the lymphatics from the tip of the tongue drain into. You have the different lymphatic groups. You have the submandibular, submental, retropharyngeal, deep cervical lymph node. So the question is, the lymphatics from the tip of the tongue is draining into which lymph node group, whether it is submandibular, submental, retropharyngeal, or deep cervical? Tip of the tongue. Yes, I think Govindindu, all of you have got it correct. Let's see. The gustatory impulses from the oral part, that is the anterior two-third of the tongue, other than the region of the circumvallate papillae, are conveyed through. We have already discussed it. Can I get the correct answer for the same? Gustatory means the taste sensation from the anterior two-third. The direct branch is not mentioned. Yes, Govind. Yes, Indu. Yes, so let's see. The next one, the general sensation from the anterior two-third of the tongue is conveyed through. General sensation, lingual, chordate tympani, A and B, internal laryngeal. Can I get the answer for the same? General sensation, yes, Indu. Anyone else giving a try? General sensation, yes, Veronica. Okay, so we'll see these after the discussion. The muscles of the tongue are developed from which part? Lingual cell swelling, tuberculum impar, hypobranchial eminence, occipital myotome. So all these are again distractors to make you go wrong. What is the answer? Muscles of tongue. So many are falling in the trap of the question setter, isn't it? No, I'm not seeing any correct answer for the same. The muscles of the tongue, the motor part. Yes, Libin. Okay. So we will see it one by one. The posterior one-third of the tongue is developed from posterior one-third, lingual swelling, tuberculum impar, A and B, hypobranchial eminence. Can I get the answer for the same? Posterior one-third. We will discuss all these and we'll come back to it. Idea. Okay, so I think you need some brushing up of your memory, isn't it? Which pharyngeal arch is concerned with the development of posterior most part of the tongue? Which one? Posterior most. I think you need some brushing up. So you have the internal jugular vein, you have the omohyoid crossing it. You have the submental line just below the tip of the tongue. You have the submandibular on the sides. Okay, and you have the jugulodigastric in the upper part, and you have the jugulo-omohyoid in the lower part. Okay, so jugulodigastric is actually the group of lymph nodes which are draining the tonsil. The principal lymph node of tonsil is jugulodigastric. And jugulo-omohyoid is actually the principal lymph node of the tongue. So there are some lymph nodes which are getting the major portion of its lymphatic drainage. You call it as principal lymph nodes. So jugulodigastric is the one for the tonsil, whereas jugulo-omohyoid is the one with the tongue. But our question was different. To which part of these lymph nodes you have the tip of the tongue draining? That was the question. Okay, we'll come to it. Now coming to the sensations, the general sensations of the anterior two-third of the tongue. You have the anterior two-third of the tongue, the general sensation coming through lingual nerve. What about chordate tympani? Chordate tympani is giving the taste sensation fibers to the anterior two-third. The posterior aspect, you have the general as well as taste sensation coming through glossopharyngeal nerve, and the posterior most part, it is having the branch from the vagus nerve through the internal laryngeal nerve. So this is again a very important concept you need to know. The general sensation and taste sensation. The only difference is the anterior two-third of the tongue, except for the circumvallate papillae, you have the taste sensation through the chordate tympani, which is a branch of the facial nerve. Whereas all the rest of the regions, the anterior two-third, posterior one-third, posterior most, all are having one single nerve, isn't it? Posterior one-third, you have the glossopharyngeal supplying the general and taste. Posterior most, you have the vagus nerve supplying the general and taste. But anterior two-third, you have special fibers of chordate tympani, which is supplying taste fibers. Okay. Now, another important thing which you need to know is about the taste component. You can see that the chordate tympani is actually coming from the facial nerve, the geniculate ganglion of the facial nerve. So that is actually giving the taste fibers. The glossopharyngeal and the internal laryngeal. So what is there in common for all the three taste fibers? So there is a nucleus which is concerned with the taste sensation. Can someone say what is the nucleus seen in relation to these taste fibers in common? When you think about the chordae tympani, the glossopharyngeal and vagus, that is 7, 9 and 10. There is a nucleus connecting all the three with respect to the taste function. Can someone say that? Just type it. You can just type the three capital letters. The nucleus concerned with taste connecting these three cranial nerves, 7, 9 and 10. Can you name that nucleus? It is shown there. Three capital letters, short form. Can I get the answer for the same? It is the nucleus of Tractus solitarius, NTS. Okay, so you can get a question like NTS includes, nucleus of Tractus solitarius include, which all nerves? So you have the chordae tympani, you have the glossopharyngeal, and you have the vagus, 7, 9, and 10. Okay, so you have to think about that also. You have the facial nerve giving of the chordae tympani, you have the glossopharyngeal, and you have the vagus nerve through internal laryngeal. Now coming to the pharyngeal arches. If you need a detailed session, you can just search my classes in the YouTube. We are just brushing through the important aspects. You can see that there are 1, 2, 3, 4 and 6. Fifth arch is actually disappearing, hence we are not showing it. Now, first arch components, you have the lingual swellings and the tuberculum impar. And you can see that this arch is exclusively giving rise to the anterior two-thirds of the tongue, isn't it? Two lingual swellings and the tuberculum impar. Then in the second part, the second arch, you are not showing, there is no structure shown here, isn't it? So what is the reason for that? During development, what happens is this third arch, the region here, is actually trying to touch the first arch. So this second arch is embedded, and as a result, no structure is derived from the second arch. Okay, so this part is very, very important. So there is no contribution from the second arch. Then you have from the third and fourth arch, you have the hypobranchial eminence. So cranial part and the caudal part of the hypobranchial eminence. You have the posterior one-third and posterior most part of the tongue developed. So the lymphatics from the tip of the tongue, we have already shown the tip of the tongue. The lymph node which is lying closer to the tip of the tongue is the submental lymph node, which is the principal lymph node of the tongue. So tip of the tongue is a different question, but the principal lymph node of the tongue. Can I get the answer for the same? Yes, very good. I mean, you're jumping into conclusions. Yes, it is the jugulo-omohyoid. Now the gustatory from the anterior two-third, it's very easy again. Can I see the answer? Gustatory, taste sensation, anterior two-third is a branch of anterior two-third. Yes, Varunka, Libin, Vaishak, Indu, many are very attentive. I'm happy for you all. So it is a facial nerve which is giving off the chordae tympani. The general sensation, anterior two-third, which is that? There is a distractor again here, A and B. Yes, general sensation, yes, right. Indu, Libin. So general sensation is just the lingual nerve. Now coming to the major question. The muscles of the tongue, which all of you have gone wrong. I didn't see any correct answer. Can I get the answer for this? Muscles of the tongue. Yes, Libin. So it is the occipital myotome. All these lingual swellings, tuberculum impar, hypobranchial eminence, we were saying were actually concerned with the dorsum of the tongue, the anterior to the posterior one, that posterior most. But the muscular component of the tongue is coming from the, yes, Varunka, it is from the occipital myotome. Very, very important. So most of you jump into conclusion and pick from the three which you are quite familiar with. Okay, so please keep that in mind and please don't jump into conclusion. The posterior one-third of the tongue is developed from Now can you answer this? Posterior 1/3. Again, there is a distractor, right? So what is the answer? Yes, Leben, Vaishak, Varanga. I think it has worked. The explanation, it is the hypobranchial eminence. Which pharyngeal arch is concerned with the posterior most part? 1, 2, 3, 4, and 6 we have mentioned. Posterior most part. Can I get the answer here? Yes, Vaishak. So it is the fourth one. Okay, so third and fourth together forms a hypobranchial eminence with the cranial and caudal part. The caudal part of the hypobranchial eminence from the fourth part is giving rise to the posterior most part. Now coming to the next concept, the palatine aponeurosis. So, which is the structure forming the palatine aponeurosis? Tensor palatini, levator palatini, palatoglossus, palatopharyngeus, all are connected to the palate, out of which is resulting in the formation of the palatine aponeurosis. So you can see the pterygoid hamulus here. You can see the muscle tensor palatini actually winding around the pterygoid hamulus on its way to the palate. And in the midline, you can see the musculus ovale. Then you can see loops, isn't it? From above, you have the levator palatini. From below, you have the palatoglossus, palatopharyngeus. So, which is the one which is forming the aponeurosis. That is the tensor palatini, which is winding around the pterygoid hamulus and getting inserted as the aponeurosis. The only muscle of the soft palate not supplied by the pharyngeal plexus. Tensor, levator, palatoglossus, palatopharyngeus, musculus ovale. So even if you don't know anything about the pharyngeal plexus, from the previous discussion, we have discussed something which will help you to answer this. Can I see someone answering it correctly? Yes, Indu. Leben. Yes. So all of you are attending. Very happy. So what is the answer for the same? It is tensor because tensor veli palatini and tensor tympani. They are supplied by the mandibular nerve from the trunk of the mandibular nerve through the nerve to medial pterygoid. Okay, so even if you don't know anything about the pharyngeal plexus here, you know that tensor palatini is not supplied by the pharyngeal plexus. And again, that is an exception also for the soft palate. So very, very important. You have to remember this point as well. Okay. Which pharyngeal pouch is concerned with the development of the palatine tonsil? First, second, third, fourth. Can I get the answer for this? Tonsil is derived from which pouch? Fourth, why? Why, Varunka? I think you need a brush up here. So this is the palatine tonsil and this is the palatine tonsil which we call as tonsil. So there are many different types of tonsil. You know the lingual tonsil behind the tongue. Here you have the lingual tonsil. Then on either side, you have the palatine tonsil in the tonsilla fossa. Then in the nasopharynx, you have the nasopharyngeal tonsil. Then at the opening of the auditory tube, you have the tubal tonsil. All these are tonsils, but normally when we say about tonsil, we usually refer to the palatine tonsils. Okay, so the palatine tonsil, they are derived from the second pharyngeal pouch. Because of lack of time, we are not able to finish all the pouches and all. So please read about it. Again, they are very important. The anterior border of the palatine tonsil is related to. This is again a very easy question. Soft palate, tongue, palatoglossal arch, palatopharyngeal arch. Anterior border of palatine tonsil. Can I get the answer for the same? So you can see that in the oral cavity, you have the oropharynx where you have the tonsilla fossa formed by the two arches. Anteriorly, you have the palatoglossal arch and posteriorly, you have the palatopharyngeal arch. Okay, so the arch related here is the palatoglossal arch. The posterior border is the palatopharyngeal. So anterior border, it is the palatoglossal arch, which is the principal artery of the palatine tonsil. Can I get the answer for this? Principal artery supplying the tonsil: lingual, facial, ascending pharyngeal, greater palatine. Principal artery of the palatine tonsil: lingual, facial, ascending pharyngeal, greater palatine, which is the artery supplying, it is the facial artery. Okay, the principal artery, the main branch. Which of the following is usually a source of severe bleeding during tonsillectomy? So after tonsillectomy, we are usually afraid about post-tonsillectomy. We always look for the serious bleeds, which can turn fatal. Okay. So what are the options? You have the facial artery, the principal artery. You have the branches from the lingual artery, maxillary artery. Then you have the veins lying closer to it. So out of the options given here, again, it's a distractor. Yes, Varunka into. So though it's a distractor, sometimes it can be the answer also. Okay. So it is from the vein, the venous bleed, which is more common. The principal lymph node draining the palatine tonsil. I have discussed the answer. Yes, yes. Varunka, you have typed it again. Correct. Second time, you have made it correct. Okay, so jugulodigastric, it is the principal lymph node of the tonsil, whereas jugulo-omohyoid is the principal lymph node of the tongue. Okay. Now, referred pain to the middle ear from the infected tonsil is due to the innervation of both by which nerve? So there is a nerve having contribution to the tonsil as well as to the middle ear, which is the nerve. So many are having different options. So it is the glossopharyngeal nerve. Okay, so which is having, so glossopharyngeal nerve is the nerve seen in the interior of the middle ear, and it has also got some branches to the tonsil. The term adenoid is used for the enlargement of which structure? So you have a cluster of tonsils here: tubal, nasopharyngeal, palatine, lingual. So you know adenoid is, yes, very good. So Indu, Varun, Kavaish, all of you know the answer. So it is the nasopharyngeal tonsil which is seen in the roof of the nasopharynx. If enlarged, usually seen in children, you call it as adenoids. The following statements are true about the olfactory nerve except they occupy the superior part of the nasal cavity. They are the first order receptor neurons in the olfactory pathway. They are capable of regeneration. Their axons enter the cranial cavity through the posterior ethmoidal foramen. Can I get the answer? It's very easy actually. Olfactory neurons. Though the statements are bigger, the answer is very simple. Can I get the answer for the same? I'm waiting for the correct answer. So you have the olfactory neurons passing through the cribriform plate of the ethmoid bone, not through the posterior ethmoidal foramen, okay, to enter into the cranial cavity. Okay, and they end in the olfactory bulb, which is there in the anterior cranial fossa. So they are the first order neurons. So the answer here is they are not entering through the posterior ethmoidal foramen. They are entering through the cribriform plate of the ethmoid bone. So if you know that concept, even if you don't know the rest of it, you can give the correct answer for the same. The olfactory cells are what type of cells? Unipolar, bipolar, pseudo-unipolar, multipolar. Can I get the answer? It is definitely not multipolar. That you can at least omit out because it's not a motor nerve, right? So out of the other three options, which can it be? It is an example of bipolar. Okay. The following structures form the nasal septum except nasal septum. So nasal septum is actually formed by three important structures, isn't it? So which is the exception? Descending process of lacrimal, septal cartilage, vomer, perpendicular plate of ethmoid bone. So can I get the answer for the same? The nasal septum. Now can I get the answer? So let's see which are the contributors for the septum. You have the vomer, which is a single bone line in the midline. Then you have the perpendicular plate of ethmoid bone, and then you have the septal cartilage. So altogether, if you look at the nasal septum, and if you divide into three parts, 2/3 is actually formed by the bone. You have the ethmoid and vomer, isn't it? Whereas the 1/3, the anterior 1/3, is formed by the septal cartilage. Did you get me? So it is the ethmoid vomer and the septal cartilage, whereas the lacrimal bone is not having any major contribution. Okay, so did you get me? So the answer here is the descending process of lacrimal bone. Now, which of the following is not a part of ethmoid bone? This is again a very easy question. Which of the following is not a part of ethmoid bone? Yes, all of you know it, right? Veronica Libin, you have to think again. So let's see. This is the inferior concha, this is middle concha, this is superior concha. Now, if you remove the mucous membrane, this is how it looks. Inferior concha is a different color, right? The middle concha, the superior concha, the cribriform plate all belong to one single color, that is ethmoid. Whereas inferior concha is actually an individual bone in the skull. It is not a projection of any other bone. Okay, so the superior concha, middle concha, and the cribriform plate of ethmoid bone. So all these belong to the ethmoid. So the answer here is inferior concha, which is actually seen as a separate bone. Excuse me. Okay, so hope that part is clear. Which is the chief nerve innervating the nasal septum? Anterior ethmoidal, nasopalatine, greater palatine, anterior superior alveolar. All these are some theory topics which you should be knowing. Okay, so I've just added those two, which is the chief nerve innervating the nasal septum. All these are again contributing, but you can see that there is one single nerve, the nasopalatine nerve, which is a branch from the maxillary coming through the sphenopalatine. So that is actually giving a major innervation to the nasal septum. Infection from the nasal cavity may spread to the following regions except. So, which are the communications the nasal cavity has got? Anterior fossa, internal ear, conjunctiva, paranasal air sinuses. Very easy, isn't it? As a doctor, you should be knowing. If you have a patient with nasal infection, which are the regions where you can get? Yes, Veronica. It is Hindu, you have to think. So what is it? It is internal ear. Anterior cranial fossa. Yes, nasal cavity is communicating with the anterior cranial fossa through the cribriform plate of ethmoid bone. We have discussed. The olfactory nerves entering into the anterior cranial fossa by piercing the cribriform plate, isn't it? Then conjunctiva. Yes, nasal cavity is having a communication with the eye through the nasolacrimal duct, isn't it? So any infection can spread there. Then paranasal air sinuses, of course, all the paranasal air sinuses are opening into the nasal cavity. So any reverse spread of infection can also happen. But internal ear, there is no communication. Okay. So this is again a very important aspect which you need to know. The communications with the nasal cavity. Frontal air sinus, nasolacrimal duct, sphenoidal air sinus, posterior ethmoidal air cells, and the rhesus and the meatus which are related. So I'm not asking you to answer it now. We'll discuss and then I'll make you answer. The following sinuses open into the hiatus semilunaris of the middle meatus, except. Can I get the answer for this? Hiatus semilunaris. Again, all these are very favorite questions for the ENT people as well. Okay. Middle, frontal, maxillary, anterior ethmoidal. Can I get the answer for this? I think many of you need to brush up their memories. So you can see that when you see the lateral wall of nose. Okay, lateral wall of nose is a very important area. You know that there are three concha and three meatus, isn't it? You have the superior, middle, and inferior concha, and you have the three meatus, superior meatus, middle meatus, and inferior meatus, isn't it? And there is a recess above the superior and in front of the sphenoid, that is the sphenoethmoidal recess, where you have the sphenoidal air sinus opening it. Now coming to the middle meatus, you can see that there is a projection in the middle meatus that is called bulla ethmoidalis. And just below the bulla ethmoidalis, there is a depression that is called hiatus semilunaris. Now, coming to the inferior meatus, there is only one single opening, that is the opening of the nasolacrimal duct. That you can easily remember. Sphenoethmoidal recess, only one sinus opening, that is sphenoidal air sinus. Inferior meatus, there is no communication of the sinus, but there is one single structure which is having a connection with the eye, that is the nasolacrimal duct. And coming to the middle meatus, you have lot of structures opening into the middle meatus. So there again, you need to know what are the structures opening into the hiatus, this depression or groove below the bulla, and what are the structures opening onto the bulla. And again, these are very favorite questions. It can be asked in anatomy as well as in ENT. So the frontal air sinus is opening into the infundibulum. This region is called infundibulum of the hiatus. Now, can you focus on these three dots? 1, 2, 3. So this can be called anterior ethmoidal, middle ethmoidal, posterior ethmoidal. So anterior ethmoidal is opening into the hiatus. Middle ethmoidal is opening onto the bulla. Posterior ethmoidal is opening into the superior meatus. So these are the three ethmoidal air sinuses. And now you can also come to a conclusion that in the superior meatus, you have only the posterior ethmoidal air sinus opening. Okay, so anterior onto the hiatus, middle onto the bulla. Now, let's see the schematic representation so that you can get a clearer version. Onto the bulla, you have the middle ethmoidal. You have the anterior ethmoidal onto the hiatus. Then you have the maxillary sinus and frontal sinus to the ends of the hiatus. And the posterior ethmoidal, the only sinus which is opening into the superior meatus. Then you have the nasolacrimal duct, the only structure opening into the inferior meatus. Okay, so this diagram, if you make it by heart, you can answer most of the questions which are related to the lateral wall of nose. Okay, and this is a very, very favorite question for the examiners. Anyway, they can ask questions with different permutations and combinations. So if you know this concept, it is very easy. Now, can you answer now? Frontal air sinus, which is the option? Yes, Indu, correct. Varunka, yes, it is the infundibulum of hiatus semilunaris. What about the next? Nasolacrimal duct. Those who are attending, they can very easily. Yes, Lal, Indu. Yes, it is the inferior meatus. We have only one opening, isn't it? Then sphenoidal air sinus. That's again one thing. Yes, Varunka. Yes, Indu. Yes, you know it. It's very easy. Sphenoid model recess. And the last one, posterior. It is again one structure which is opening into the superior meatus. Hope that concept is clear for you. Can someone type in the chat whether you are finding it useful? I'm a bit rushing through so that I feel like I can take maximum. Okay. Since I'm not seeing many people here, I was just wondering whether I'm just rushing through. Okay. Thank you so much. So now coming to the next, the following sinuses open into the hiatus semilunaris of the middle meatus, except you can very easily say it. Can I get the answer for the same? Hiatus. Which sinus is not opening into the hiatus? I'm not getting. Yes, very good, Arya, Varunka. So middle ethmoidal is actually opening onto the bulla. That is the thing which you have to remember here. Because anterior, middle, posterior, the three ethmoidal sinuses, anterior into the hiatus, middle onto the bulla, posterior onto the superior meatus. Okay, if you remember it like that, it is easy for you. Select the incorrect statement about the maxillary sinus. It is the first sinus to develop. It is the largest of all sinus. It is rarely affected. Incorrect. It's again very. Can I get the answer? I'm waiting for the answer. Yes, Varunka. Even if you don't know anything or if you've forgotten, it is very easy to answer this question, isn't it? We'll come to it. The natural drainage of the maxillary sinus is impeded because its opening into the middle meatus is narrow. Because of a larger size, placement of its opening is higher than its floor. Its base is directed towards the lateral wall. What can be the answer? It's again a very easy question. Why the drainage is impeded? We usually discuss about this a lot. Yes, Varunka. Anyone else? So let's see the maxillary sinus here. You have the hiatus semilunaris. You have the opening of the maxillary sinus. And it is the most commonly affected sinus. When you have sinusitis, it can be because when you see the aperture of the maxillary sinus, you can see that it is located superior to its floor. The floor comes somewhere here and the opening is here. So this is not permitting the natural drainage. It is anti-gravity drainage, isn't it? If the opening was here, it would have clearly drained, but the opening is higher up. So the infection, and again, the infection can spread easily from the frontal sinus because it is on its way, isn't it? So at the hiatus semilunaris, the frontal sinus infection can easily pour onto the maxillary sinus. And you have the maxilla here, you have the molar tooth. So any infection from the molar tooth can easily get into the maxillary sinus. Now we can see that the base is actually opening onto the lateral wall of the nose. So this is the opening which is above the lower limit of the maxillary sinus. So what happens? It is actually an anti-gravity mode of drainage which results in collection of fluid here and frequent infections. Okay, so you might have heard about the antral puncture, which is usually done in case of chronic sinusitis of the maxillary sinus. So what they do is they will make an opening at the level of the floor of the maxillary sinus. So this opening can be made either in the nasal cavity at the level of the inferior meatus or through the oral cavity at the canine fossa on the maxilla. So these are the two regions where they will do this antral puncture in order to drain the maxillary sinus. Okay, now can you just go through the options? with this, we will be winding up. We will be just finishing these questions and we'll be winding up because the rest of the portions need a longer time. So select the incorrect statement about the maxillary sinus. Can I get the answer for the same? Yes, most of you have got it right. It is not rarely affected. It is the sinus which is commonly affected. The natural drainage is impeded by, what is the answer? Yes, Libin, Varunka, Lal. Yes, you know it. The placement is at a higher level. Then the size of the maxillary hiatus. Do you know the answer for this? The maxillary hiatus, when you disarticulate the maxilla from the skull, what usually happens is you can see that the base of the maxilla is a big hole, isn't it? But when it is seen along with the nasal cavity, you can see that the hole is not there because it is covered by so many bones. That is what you call as the bones which reduce the opening of the maxillary hiatus, isn't it? So, what are the bones which reduce the opening of the maxillary hiatus? That is a question. So, there is a code for that that is called PULI, PULI. Have you heard about this code? The bones which reduce the maxillary hiatus, PULI. So, let's see. So P stands for perpendicular plate of palatine. U stands for uncinate process of the ethmoid. L stands for lacrimal bone. And I stands for inferior nasal concha. Okay, that is PULI. So they are the bones which actually reduce the size of the maxillary hiatus. So sphenoid is not actually forming any part of the opening of the maxillary hiatus. So with this, I'm winding up today's session. Hope this was useful for you. Many questions usually come from the mandibular nerve and the maxillary artery, infratemporal fossa, and head and neck itself. In our days, we used to have a 2 days class, full day class. But since we are running short of time, I was trying my level best to touch the major portions. Hope this was useful. Can you please type in the comment box? Okay, okay. Anyway, thank you. Thank you for letting me know. So, all the best for your future exams. Work hard and try to cover the high yielding topics, especially from the head and neck and neuro part, okay? So that you can score well. Anyway, thank you.
Madam, thank you.
Okay, thank you.